2 months, but it really helped a lot. So this invention here, you can actually hook it up to the regular flow meter. So oxygen comes from the wall. There is the flow meter right here. That flow meter that has the Thorpe tube, and there's the knob, and it goes like this. And this is the Christmas tree, and you attach this and all of these things to that Christmas tree and the green Christmas tree on the bottom. Before it reaches the flow meter, the oxygen has a opening here with a valve on it. Obviously, it was a diaphragm, so it doesn't leak oxygen all the time. But this is the one that we use, like if they want to connect a vent, you connect it from here, behind the flow meter. If you notice in the room, behind the flow meter, you can't connect the vent to flow meter. The vent needs much more flow than this. So they connect it here using the hose, the green hose for oxygen. For the heated wire high flow, there is also need to be connected here. It doesn't connect here. So you connect it here. Sometimes they connect another hose to air, which is usually yellow in color. And that big hose goes through until it reaches to a humidifier. And then it comes out from the humidifier. There is another fat Thorpe tube, if you will, and then another gauge for oxygen, how much oxygen you're giving the patient FiO2, and then it goes to the patient in a corrugated tubing, similar to the vent tubing. It doesn't look like a nasal cannula tube. It looks like a small vent tubing. It goes to the patient, and the nasal cannula is huge. And the nose a little bit bigger than the other one. Okay? All of this corrugated tubing. Inside this corrugated tubing, there's a wire that goes like this, and that wire gets warmed. So when the wire is warmed, it keeps the humidity. So now you catch humidity from here, from the water, right? And then by the time you reach the patient, it will all be condensed here. So what it did is that it added humidity, so it warms here, like there's a boiler here to give you a lot of humidity, and there is the wire that keeps it warm all the way to the patient, so the patient can tolerate up to 70 liters per minute, which is amazing. Remember we said the maximum you can give on the Thorpe tube from the wall is 150 liters per minute. This is half of it, and tolerated. This one you can give it for an hour or two, and then the patient is gonna feel like headache and stuff like that. This one you can do it forever, for weeks. So that's your heated wire high flow. The fat flow meter here doesn't go like the other one. Doesn't go 2, 4, 5, whatever. It goes 5, 10, 20, all the way to 70 liters. So it's a fat tube, and this is 100%. It goes 100%, 90%, 80%. This is just the FiO2. If you change that training, you can do 100%, so everything is coming from here. If you go 80%, then it will entrain from the air and put 20%, like it mixes it to mix the FiO2, whatever you want. And what that does is that it fills the nose, fills the nasopharynx, fills the oropharynx, fills the mouth, fills the hypopharynx, and comes out of the mouth and makes a halo of oxygen around the patient. If you have a Geiger counter, the patient will look like Jesus. Be like a halo of oxygen around the patient. And anywhere the patient, from any place, even if the patient breathes from his ears, he has a trachea in his ear, and he breathes from there, it would be 100% oxygen, even though the thing in his nose. If the thing falls from his nose, it's going to be 100% oxygen, because all the way to 70 liters, if he's doing like this, he can actually get all of what he wants oxygen. So oxygen is all around. They don't mix that fast. When you have a lot of oxygen, it pushes the air a little bit around it like this. It does mix, obviously, but if there's always continuous flow of oxygen, you're always surrounded with oxygen. So that's how you get almost 100% here. This actually, there has been studies, and I've been surprised. The studies actually showed that the heated wire high flow nasal cannula is better than BiPAP in the treatment of all respiratory failures. I don't have a mechanism. I mean, the mechanism is weird, because I know it's probably better for maybe hypoxic patients, patients who are hypoxic, and but they have good gas exchange and everything, I think it should be okay. But for patients who are hypercarbic, and we're giving this, and they still do better according to the study, I'm suspicious. But that's a study out there. There's a lot of studies about the heated wire high flow that makes you wonder. But it's all out there. So keep that in mind. It's not a bad idea. I think these studies were done in the American population, where all of us are fat, have all of this obesity thing. So as we, sleep apnea like myself, if you put the patient, the oxygen, the heated wire high flow in the patient's nose, chances are they have a little bit of PEEP, because 70 liters, a little bit of PEEP pushes all of this away. If there's a little bit of bronchospasm, pushes a little bit the bronchi, open a little bit the bronchi a little bit, and maybe that's why they're having better outcome, especially that they can now clear the secretions as opposed to BiPAP, right? So there's a lot of also studies that show that extubating people to heated wire high flow after cardiothoracic surgery, even if they don't need it, just the fact that they're giving 70 liters per minute and titrating the oxygen maybe to 40%, it doesn't matter, but 70 liters per minute, that actually makes them do better. There's controversy about that. There's also, in general, extubation too, like they did a study, extubation of all of your ICU patients to heated wire high flow as opposed to a regular nasal cannula. It showed that it's better than that. So there's a lot of application for the heated wire high flow. How do you wean the oxygen on the heated wire high flow? Weaning oxygen, it's gonna be, or weaning the patient off, it has to be weaned FiO2 first. So the FiO2 will be weaned first until it reaches to 50%, and then the liters of oxygen will be weaned second. If you're at 50% and 30 liters, chances are you can tolerate 15 liters 100%. Sometimes we cut it even short at 40 liters or something. We jump to the 15 liter 100%. Okay, so that's how you wean it. I like to wean the FiO2 first, because if I wean the liters first, what's going to happen? That halo effect is going to decrease. So I don't know, I'm decreasing the liter, but I don't know how much FiO2 I'm giving. I'm dialing 100%, but it's not 100%. I'm draining more because there's less halo. That's number one. Number two, which one of these two, the FiO2 versus the liter, which one is beneficial to the patient, if you will? But both of them give you high oxygenation, improved oxygenation. But which one is a treatment? The liters. I mean, the liters is the PEEP. The FiO2 is just FiO2. In fact, some people argue it's injurious to the patient to have a high FiO2. So I would wean it this way. Now, there's a little complication here. In COVID patients, this is the one that the CDC is recommending against, or I don't know, they keep changing every day. They work recommending against, now they're silent. We used it from the beginning. I mean, it's just like the first week or two that we started intubating everybody who comes from the floor, because that was the recommendation. Everybody who needs any support, whether this or BiPAP, they have to intubate them to protect the staff, not to protect the patient. So basically, we're protecting ourselves, we're being like very, very vigilant about protecting ourselves, but the patient is doing worse. Because we're intubating them, they lose their kidneys, you have to give them a little bit of fluid, positive pressure ventilation, their lungs fill up, you can't extubate them, all of these things. So obviously we abandoned this immediately after the 2 weeks, and throughout the whole epidemic we were doing this and BiPAP and other stuff, but with more protection for as much as we can for the staff. We're doing the tent, we're doing things to protect direct exposure to the droplet that forms from this. So in the COVID epidemic, we kind of change our approach to this a little bit to protect the staff. I mean, that's it's not like we're hurting the patient. If I wanna that much, if we are at the 70 liters, we always start at 70 liters and 100%. if we're at 70 liter 100%, instead of weaning the FiO2 first, we wean the liter first. Because the liters are that's what's gonna get you, as far as providers. So in that situation, I think it's reasonable to say, okay, wean the liters first if you have COVID, and leave the 100%, and then that'll be the last thing to be weaned, just to protect people. Now the last thing we're gonna talk about is the helmet. So the COVID helmet, it's actually been invented long time ago. When I was a fellow, like in the dark ages, in the late 90s, Italy invented the halo, but nobody used it. It was only in Mass General. I've seen it only in Mass General, and I'm sure other hospitals had it, but never had a use in the United States really. So somebody during the epidemic, in Texas, I think he was a respiratory therapist here in the New England area. I think at Mass General maybe, because he talks a lot about a lot of hospitals here that he knows people in these hospitals, and he retired in Texas. And when the epidemic happened, he decided to make his garage a factory that makes the helmets. So that's where we bought the helmets from. It's not that expensive. It's about $300, and you can obviously use it for the same patient. And you can even, in cases of real shortage of everything, you can actually send it to Central Supply and they can clean it. They can sterilize it for the next use. It's a little bit, but in case you're running out of people on the floors, on a literal floor everywhere, and you want to use that, you can use it. So how does the helmet work? So the helmet looks like this, and literally like Sandy, Sandy in SpongeBob. Yeah, that's Sandy. So this is like a blue plastic thing, area here. The key here is the diaphragm. There's like a very thin diaphragm of latex or latex-like material here that actually has to be fitted to your neck, because we can't put something, you choke the patient. We just put something loose that they can move his neck. It doesn't feel anything. It's very loose. So that's why it's not something that is actually very much fitted to the patient's neck. It's just loosely fitted to the patient's neck. So what we do is that we measure the patient's neck, like actually put a tape and measure the patient's neck, and then come up with that measurement, and then cut the diaphragm. So use the scissors, and they have grades, they have all of the diameters, and you cut the diaphragm, the circle that represents the patient's neck to the best of your ability. There's a line, you cut on that line, and just fit it over the patient's head. It has straps that go under the patient's axilla, because if not, it'll take his head, and actually he'll have a long neck. It actually flies. So you strap it under the patient's axilla, and it has this blue thing here has a lot of like knobs like this, so you can put the strap on and kind of hook the strap on it, or hook many things on it. All right. Now it has something, we call it the cow otter. It goes like this. All right.
Good morning to our patients, guests, and employees. Please make it a safe and exceptional day.
And it has three prongs like this, and that is each one of them is connected to a flow meter. So you have to do it in a room. You don't have to, but ideally you should do it in a room that has 3 flow meters, and connect each one of them to a flow meter with an oxygen tubing. There's oxygen tubing, right? This flow meter, run it as the highest, which is the highest is 150, and this was 150, and this is 150. So you have 450 liters flow for this patient. It's an amazing amount of flow. He will never retain CO2. I've never seen any one of them retain CO2. I thought that this would be a problem with the machine. It doesn't. It doesn't retain CO2. So the amount of flow will actually, some of the flow will escape here of the oxygen around the neck, but the amount that's going in is so much that it's always inflated like this. Like it doesn't lose. The inflation is always inflated like this, and you know that this is all 100% oxygen, and anywhere he's gonna breathe is gonna be 100% oxygen. And to my surprise is that these patients actually loved it. They always sleep on it. You put somebody on it, they sleep. I don't know why. What makes them sleep when they go under this, because the CO2 is not higher, but they just sleep. I think the BiPAP is just so much, like it really, it's annoying to the patient. And this one is just like nothing on your face. Suddenly, after being here for like a week and we're doing things and nasal cannula, suddenly you don't feel anything on your face, and then they immediately go to sleep. So that's why we decided. Nobody knows. We came up with our protocol here. It is involved to put the patient on. It's not going to be able to eat, obviously, and taking it off, and it can actually rip the diaphragm. Happened to me once. We had to actually, during the epidemic, tape it because we didn't have any. So anyway, so you put it on, you put it off, all of these things. But so instead of doing it multiple times, you know how we do BiPAP 4 hours on and 4 hours off, alternating with the heated wire high flow? We said, okay, the 8 hours of the night, do this. So this patient can have multiple things. Can have BiPAP in the morning for recruitment, a couple of times. Can have heated wire high flow when he wants to eat, right? About 8 hours of the day. And the 8 hours of the day continuously he's gonna go on BiPAP throughout the night. So he can sleep and doesn't have anything on his face. So that technique works great for our patients. We had a couple of patients who actually even, they did so well that one of them stayed like a month on this. Every night he takes it, and then he went to rehab, and rehab had to buy this for him because he couldn't tolerate without it. He got used to it, I guess. And I hear that he's been 6 months in rehab using this at night. Whatever it is, but I'm sure the question in everybody's head now is that oxygen toxicity, right? Everybody's like, what about oxygen toxicity? It's bullshit. Well, how does oxygen toxicity happen? So oxygen toxicity, people think that oxygen itself as a substance, I don't know how, like oxygen in the air turns into ozone or something. I have no idea. I mean, inside the lung is going to turn into ozone. They always think about free radicals, free radicals, free radicals. How is the oxygen causing free radicals? If it causes free radicals, why doesn't it cause free radicals anywhere? On the skin, it doesn't cause. So there's something missing. There is oxygen toxicity, but not the way they describe it to us. It's actually, it is all related to something called absorption atelectasis. So out of the three things that we inhale, nitrogen, CO2, and oxygen, oxygen is in the middle one. So basically CO2 is the fastest diffusible across the semipermeable membrane, followed by oxygen, and the least or the latest one to diffuse across the semipermeable membrane is nitrogen. So when we inhale regular air, 21% oxygen, 79% nitrogen, that's actually good, because the lower parts of the lung where they have an alveolus is already like not 100% open, it's like smaller alveoli. As the oxygen, we give more time for inhalation, the oxygen diffuses into the hemoglobin, right? But the nitrogen stays, and that's what keeps the alveolus open, and then CO2 comes, because closing the alveolus is a disaster. If you put somebody on 100% oxygen for a long period of time, what's going to happen is that they will collapse their alveoli, because in certain areas of the lung, the 100% of oxygen is going to really go all the way out, and the alveolus is going to close. And once the alveolus closes and you open it again with the next breath, that potentially can result in atelectrauma, which is shearing forces on the alveoli, resulting in free radicals. That's one mechanism of oxygen toxicity. The oxygen itself doesn't cause that, because all of these devices that we came up with in the last 10 years, they're 100% oxygen. So explain to me why 100% oxygen on a vent causes oxygen toxicity, and this one is the standard of care of treatment of influenza patients, right? There's no explanation other than absorption atelectasis and stuff like that. And this one doesn't open, that doesn't go the 100%. By the time it reaches the alveoli that are already going to collapse, it's not 100% anymore. There's a lot of CO2 there, especially that if you're not on the vent. So there's some protection from the oxygen.
Wouldn't the PEEP help you a little bit too with that?
Yeah, yeah. Well, but people who advocate for oxygen toxicity, they say oxygen toxicity on the vent
Oh,
with PEEP and everything.
no.
I'm not debating that there's oxygen toxicity, but I'm just saying it is not like instantly. You put the patient, if there's an oxygen toxicity, then everybody will get oxygen toxicity from the first hour of 100%. You put them on 100%, then you should get some sort of toxicity. Doesn't happen unless you leave him for days on it, especially on the vent, because the vent actually pushes air into areas that are not opened by in regular not opening the lower parts of my lung. The vent opens and fills them with 100% oxygen, and then 100% oxygen diffuses completely out, so they close, and then the vent opens them the second time. So then they have the shearing forces. Here, there's not. If it's closed, it's gonna be closed. That PEEP is not as much. Yeah. So anyway, so that's that. We'll stop here. Any questions? I love it.